is part one of ARDS. There's going to be a part two on Friday. Feel free to stop me at any point if you have any questions or if something is not clear. This is an outline of what we will be going over today and on Friday. So history and definitions, epidemiology, etiology, pathogenesis, ventilator strategies. This is the bulk of it. It's really for today is going to go ventilator strategies. We're going to be talking about ventilator-induced lung injury, lung protective ventilation, going over tidal volume and PEEP. And then for the second half of the talk on Friday, we're going to be talking about other ventilator modes, recruitment maneuvers, and other therapies. So a little bit of a historic perspective. This is a frequently cited study because it was the first description that we know of what we now call ARDS from 1967. And the reason it was first described in 1967 is this was early in the days of positive mechanical ventilation. So to recognize it as a syndrome, we really needed positive mechanical ventilation. And this was in 1967 in a military hospital in Vietnam, actually, where Ashbach and colleagues described 12 patients with acute respiratory distress, severe hypoxemia, and low lung compliance. This was the key feature that previously would not have been recognized. And on their X-ray, they saw diffuse infiltrates. This is what the X-ray looked like on their publication. This was from Lancet, 1967. Of note, they submitted this manuscript to the New England Journal of Medicine, but it was rejected. They thought, oh no, this is not something new. It was, but reviewers can be tough sometimes. And this was, most of these patients died, or maybe all of them died, so they had autopsy. And they showed what we now call diffuse alveolar damage. The current definition that we use for ARDS remains the Berlin definition, which includes these criteria. So timing within 1 week of known clinical insult. On chest imaging, there's bilateral opacities that are not fully explained by another process like effusions, lobar or lung collapse or nodules. The origin of edema is not fully explained by cardiac failure or fluid overload. Need objective assessment if there is suspicion for that, like an echo. In an older definition, there used to be a wedge pressure included. It's not included here because this is not frequently obtained these days. And in terms of the severity of hypoxemia, it is defined as a PF ratio. And the PF ratio is, that's what defines severity. So that's a PaO2 over FiO2 ratio of less than 300. All of them have to be less than 300, but if it's 200 to 300, that's mild. 100 to 200 is moderate, less than 100 is severe. Now, some of the studies that I'm going to go over used an older definition, which split it into acute lung injury and ARDS. And back then, what we now call mild ARDS was called acute lung injury, meaning it used the 200 to 300 PF ratio. So what is the most common cause of ARDS? Is it severe sepsis from pneumonia, severe sepsis from other sources, trauma, or transfusion reaction? Any takers? The first one, yes, that is correct. So this is from back in 2005, a population study that looked at the different causes, and by far sepsis is the most common cause. So the two biggest pieces of the pie here are sepsis from a pulmonary cause and sepsis from a non-pulmonary cause. And the rest are witnessed aspiration, trauma, and we have other things that are less common, like pancreatitis, drug overdose, transfusion, and then the 14% here is other. These are percentages. This is the same study, and it looked at how common it is, and it is fairly common. Now, keeping in mind that ARDS is not a disease, it's a syndrome, meaning, and as the definition suggests, it is the result, it is lung injury caused by another disease, and it's caused by sepsis, which in itself is a syndrome caused by infection. So this is part of the reason that when we talk about treatment, there is not a specific treatment, because we're not talking about treating a specific disease. But we will get to that. That being said, this was the number of cases. So the crude incidence in person years per 100,000 is 78. Again, this is acute lung injury and ARDS, what I was referring to earlier. Age-adjusted incidence, 82. Mortality is what I really wanted to point out, 38% for acute lung injury and 41% for ARDS. This was from 2005. Nowadays, mortality is a little significantly better than this. It's still high, but we're talking about 30% rather than 40%. In terms of pathogenesis, we think of it in stages. It's not as clean. There's a lot of overlap, and but this is a good way to think about it. So the early stage is edema, and that's first day primarily. It subsides over the second day. And then the next day, there's a hyaline membrane that forms. That's this protein exudate that exits from the capillary space to the alveolar space, and then forms what is termed a hyaline membrane that's based on morphology under a microscope. And interstitial inflammation, which is an inflammatory cell infiltrate, starts in the first 2 days and persists over first 2 weeks. And then fibrosis does not develop in everybody. Actually, most patients do not, long-term, do not develop at least imaging evidence of fibrosis. Many do, but, and I don't think we have tools to predict who will and who will not go on to develop fibrosis. But as is often the case with inflammation, it either results by healing and clearance of the inflammatory components, or there is scarring and long-term fibrosis. I am not going to go over the details of this cartoon. Actually, you can't even see them. But I wanted to point out a couple of things. One is, this is just showing the healthy lung on the left of the left image, and then what is happening during the acute phase. So notice the breaking in the barrier. That's really the main thing that I wanted to point out on this one. There is a lot of inflammatory cells, a lot of cytokines are mentioned here. This water here is the edema. So the earlier phase is marked by barrier breaking and edema. The later stages are marked by alveolar cell infiltration, and then this is the collagen fiber deposition and fibrosis. The rest of today's talk is going to be about ventilator management. As I mentioned, Because ARDS is not a specific disease entity, it is the result of different diseases. A lot of the time, the vast majority of them is really infection. The treatment is always going to be treat the infection, but the end result is damage to the lung. And our goal in treating ARDS is to decrease the damage to the lung as much as possible. Now, because they're so hypoxic, they require ventilator support. The ventilator, unfortunately, is necessary for improving their oxygenation, but is also implicated in further damaging the lung. So this is the concept of ventilator-induced lung injury. And there are different types of lung injury that have been associated with the ventilator, different categories. No, this picture is small, but so this is a picture of an ARDS lung. One thing that you can notice, even though it's small, you can appreciate that there is a big difference between dependent and non-dependent part of the lung and how much aeration you have. This is at end expiration and this is at end inspiration. So you can see that at end of inspiration, you recruit some of the alveolar spaces. You do get some inflation, but still there are parts that are not fully inflated. This is looking at an animal lung, and this is what it looks like at the end of expiration, and this is what it looks like when it's over-distended. So over-distension in itself leads to stretch injury. That's volume-induced lung injury, or volume trauma is what it's often termed. So you often hear the terms barotrauma and volume trauma. They're not really that different. We're talking about either the effect of the volume on the lung or the effect of pressure. They often go hand in hand because the more volume you deliver, the higher the pressure, and so forth, and vice versa. So that is intuitive. If you give more tidal volume or you give higher ventilator pressure, you're going to get more of that. We often think of barotrauma as a more gross injury, like pneumothorax and pneumodistinum. But when we use the term volume trauma, we often think of it at a more microscopic level, injuring the alveolar membranes. That's one thing. And when we talk about ventilator-induced lung injury, we're more concerned with the latter, with the microscopic level of injury. The other type of ventilator-induced lung injury is the frequent inflation and deflation leads to what is called atelected trauma. So especially this is when the alveoli are deflated all the way to the end, at the end of expiration. And then you inflate them the next time, and then you deflate them again. This leads, it is harder to inflate them each time when they're fully deflated. And this leads to shear forces on the alveolar wall that is called, these are tangential to the alveolar walls, unlike inflating them, which are sort of vertical to them. And this is what is termed atelected trauma. Now, both of these types of injury, these are mechanical forces, but they lead to release of inflammatory cytokines from the alveolar epithelial cells. And the biological effect of the mechanical forces is termed biotrauma. Now, the exact terminology isn't as important. What is important to remember is it matters how much volume you use, how much pressure you use, and how much you allow the alveoli to deflate in between your breaths. And this not only matters for the direct mechanical damage that you cause, but also because this mechanical damage further increases the inflammation that is already happening. And there is clear evidence that this happens from animal studies and from BAL samples from humans with ARDS. Now, there is this concept of patient self-induced lung injury, which has the funny acronym PSILI, which sounds like be silly. This is a little bit debatable. There's many papers on it. There are some groups that believe in it and try to prevent it, and some others that do not believe in it. There are no clinical trials showing that preventing this changes outcome. This is why it is controversial. And the concept here is not ventilator-induced lung injury, but rather in a spontaneously breathing patient, either on the ventilator due to their own spontaneous breaths while they're on the vent, or patients who have not been intubated yet, who are spontaneously breathing by their own spontaneous effort when they take deep breaths, that they take big tidal volumes, and this can lead to same forces like volume basically. Now, you can make the physiological argument that the transmural pressure across the alveolar epithelial cell is similar, whether you're breathing spontaneously or whether it is a breath delivered through the ventilator. And this is what this figure is trying to show. So this is a patient that is on the ventilator. You're giving a breath with a positive, with a pressure of 30, and then the pleural pressure is 10. The transmural pressure here is 20. And then this is the patient making a spontaneous effort, trying to take a deep breath. Because they have air hunger, they make a big effort. The pleural pressure drops to minus 20. Now the transmural pressure is 50. It is as if you are delivering an inspiratory pressure of 50. So people who believe in this PCLE argue that this is dangerous. You are subjecting the alveoli to a pressure of 50. People who don't believe in it argue that no, this is not the same because this isn't positive pressure. This is physiologic. People who exercise do this all the time, and it's fine. Now, we know that these pressure swings do happen. Whether or not they are deleterious is not very clear. What is more important, the reason it's important to find out is if you believe they're harmful, you want to suppress them. And the way to do that is by sedating people. But then you're going to end up over sedating some people and potentially paralyzing them. And that is in itself carries its own risk. So is it worth the risk? And the answer is we don't know. I mean, some people will tell you yes, and some people will tell you no. So honestly, I have my biases, but I think both camps have their biases too. So I just want you will see papers about this. I want you to be aware that it exists, and that you'll read some papers that talk about it definitively. Just be aware that the concept is controversial and that we do not have definitive data about it. There are no clinical trials showing that, and some people argue actually early in the COVID pandemic, there was papers arguing that we should intubate COVID patients early to prevent this from happening while they're spontaneously breathing. Our experience from COVID patients now tell us that people who were intubated early actually did not do well. So I'm not saying that that means that this concept is false. I'm saying that their conclusion that they reached on that population was inaccurate. All right, moving on. This is the key concept that drives our understanding of ventilator management in ARDS, which is the pressure volume curve. Now, this doesn't only this applies to anybody, but it takes this specific shape in patients with ARDS because they have low lung compliance or increased elastance. So this is volume on the y-axis, pressure on the x-axis. And as you increase pressure, the lung volume goes up. The 2 points that matter here are when you have a more bang for your buck, so to speak. When the increase in airway pressure results in a more significant increase in lung volume. So early on, when the alveoli are relatively collapsed, you do not get a good response, meaning it takes a lot of pressure to just get a little bit of air. It's like inflating a balloon when it's totally collapsed. Early on, you have to really go hard and you don't get much. At some point, you reach the balloon becomes more responsive. And this is this point, and that's called the inflection point. And then you get to a point where the balloon has reached its natural capacity. And beyond that, you're over-distending it. So ideally, you want to ventilate the patients along this portion of the curve. You don't want to allow the alveoli to collapse to below this point, and you don't want to over-distend them above this upper deflection. To prevent the collapse here, you want to set your PEEP and the positive and expiratory pressure to just above the lower inflection point. And to prevent the over-distension here, if you're using volume control, you want to set your tidal volume to not exceed this point. That was the conception behind the early ventilator protective strategies. This is showing it graphically. So conventional ventilation, which was no PEEP and high tidal volume, leads to alveolar collapse and over-distension during inspiration. Protective ventilation uses some PEEP so that the alveoli do not collapse at the end of expiration, and you do not over-distend them at the end of inspiration. And this was exactly what was done by this trial back in 1998. Small trial. They used a tidal volume of 6 versus 12 cc's per kg. The way they set the PEEP is by measuring this inflection point. So they used some version of a spirometer to measure to look at the tidal volume. It's a balloon actually. To look at the tidal volume, or not the tidal, the volume of the lungs and the pressure at any point during the respiratory cycle. And they determined for each individual patient. It was very cumbersome because you have to do it for each individual patient, and this is going to be different. And the mean PEEP that they ended up using for the intervention group was 16. So it was a high PEEP. The control group, they used the lowest needed, meaning they used whatever PEEP they thought was appropriate to achieve good oxygenation. And the mean was used was 8.7. And they had a substantial improvement in survival. Now, it's a small study, and it was done in South America, I want to say Brazil, but it can be criticized because number one, it's very small. It had 53 patients total, and most of them had a parasitic infection as opposed to their ARDS, leptospirosis. So you cannot really generalize very much from it, but it was a proof of concept that you can do such an intervention and improve outcome. A somewhat similar study that was done in double the size, still relatively small, but in decent size, 103. The tidal volume was, mean was 10 and 7, and the PEEP was done using a similar strategy, and cumulative survival showed improvement with the intervention strategy versus conventional ventilation. But these early studies, now this was published in 2006, but it was actually done much earlier. It took them some years to get it all, to get their data sorted out. So this study had a lot of limitations. But these were the early genesis for the large ARDS-NET study that is widely quoted, and that is the basis for a lot of what we do, which was the high versus low tidal volume, the ARMS study. So this was a multi-center study, 861 patients with what we now call ARDS. Back then it was acute lung injury and ARDS. They calculated the predicted body weight. They used this formula in centimeters. It's actually easier if you use inches. Little note here, there's ideal body weight and predicted body weight. They can be the same thing, but they're not always the same thing because there are two different formulas for ideal body weight. One of them is the same as this, and one of them is different. So just pay attention to that. Patients randomized to either conventional tidal volume, which was termed back then as 12 mLs per kg, or lower tidal volume, which was 6 cc per kg. So these were the ventilator procedures. Tidal volume 12 per 6, 12 versus 6. Plateau pressure that was allowed was 50 versus 30. Ventilator setting needed to achieve pH, so they allowed the respiratory rate somewhere between 6 and 35, and the goal pH was 7.3 to 7.45. The rest was the same goal for I/E ratio, same goal for oxygenation, same goal, but they didn't achieve the same level of oxygenation. This is the actual tidal volume that they received. So their goal was 6 versus 12, and they were pretty close. So 6.2, 11.8 on day 1, and on day 7, 6.5, 11.4. And their plateau pressures were below 30 here and above 30 here. 30 is sort of the magic number. Our goal is to have a plateau below 30. And this is their main result. So this is looking at survival and discharge. So the top curves here are looking at survival. The solid one is the lower tidal volume, and the bottom one is the higher tidal volume. So it improves survival, and it decreased the likelihood of hospital discharge. And numerically expressed, lower tidal volume had a survival of 31%. The higher tidal volume had a survival of 39.8%. Now, multiple analyses have been done on this patient population and others, but because this was the largest study, it is the predominant one on which the analyses were done. That try to parse it out, like which patients really benefited it. Does it matter if you use low tidal volume? What if you can achieve low tidal? What if the patient has a relatively good compliance and you can get by with slightly higher tidal volume, but the plateau pressure remains below 30? Is that okay? Let me tell you what they found first, and then I'll tell you my take. So what they found was, and this one, they divided the patients by different plateau pressures. So this is plateau pressure of by quartiles. The lowest quartile, and the effect of the tidal volume on mortality. So the one that had the statistically significant survival benefit was where the plateau pressure was highest, the highest quartile of plateau pressure. The others didn't. You see that there is a trend in each of them. Actually, the strongest trend was unexpectedly in the lowest quartile. That lower tidal volume gives you a trend towards better survival, but you only see the significant benefit when your plateau pressure is high. That suggests that people whose lung is more damaged, whose lung has a higher elastance or a lower compliance, that when you give them a small amount of tidal volume, their pressure really goes up. These are the ones that benefit the most from a low tidal volume strategy. What they were trying to get at is, well, maybe not everybody with ARDS needs low tidal volume. Yes, this may be true. I mean, the data suggests that it is true. I'm not arguing with that. What I am arguing with is what's the problem with using a low tidal volume? Like, why are we looking for the patient population that you don't want to use low tidal volumes for? It is as if we're looking, oh, low tidal volumes actually work. Let's look for the patients that they are not necessary for. They work and they don't really cause much problem. I mean, they become more acidotic. If the patient becomes severely acidotic, then fine, go look at the plateau pressure and see if you can get by without it. But most of the time, they're well tolerated. And I think in none of the patient groups, there was harm from the low tidal volume. So my approach is use them in everybody. There's even data showing that low tidal volume is beneficial in patients undergoing abdominal surgery for the duration of their surgery. They don't have ARDS and they're only getting on the vent for the few hours that they're undergoing abdominal surgery, and low tidal volume is beneficial in that population. So if there is signal toward benefit in that very limited setting, I don't see a reason to look for a population that doesn't benefit from tidal volume. There is no harm as far as I can see. This is along the same lines. This is more recent. So they analyzed the same data. So they looked at multiple trials, but if you look at the patient numbers, it's actually predominated by the same patient population, the large ARDS-NET trial. They looked at the role of pulmonary elastance. And again, they looked at and elastance is essentially the inverse of compliance. So this, how stiff the lung is. It is the plateau pressure minus the PEEP divided by the tidal volume. And what they saw is essentially that the benefit of the tidal volume is greatest, of low tidal volume ventilation, is greatest when you have a high elastance. So this is probability of death, and this is low tidal volume in red and high tidal volume in blue. So probability is death is greater when you have a high tidal volume. And the difference is greater the greater the lung elastance is. It's a more robust way than this study, but it's a similar finding. Now, towards the very lowest elastance here, there is a trend, but I think that's just a function of how they did their statistics. All right, let's pick up the pace here because I want to go over the PEEP. One thing, the study about low tidal volume has come out in 2001. Despite that, it is not widely used. It's not because people are not aware of it. Everybody knows about it. So this is real world application. JAMA 2016, 3,000 cases of ARDS in 459 ICUs from 50 countries across 5 continents. And this is the distribution of tidal volume as mLs per kg of predicted body weight. This is 6 cc. No, this is 6 cc's per kg here. About 20% of the time. 8 cc's per kg, about 65% of the time. Like this should be, nobody should be getting more than 8 cc's per kg, period. Why is it not widely adopted? I think because, one, because we don't, ARDS is not a disease, as I mentioned before, we don't always diagnose it. Like we don't say this patient has ARDS, we just say this patient has respiratory failure from pneumonia. So we don't think about it that way. Two, we don't pay, even when we do, we don't bother to calculate the patient's predicted body weight and set the ventilator that way. We just let, we just pick a random 500 cc's. Three, we don't care. But this is the one intervention that has been shown to improve outcome. So I think it's really important to pay attention to it. Now, let's see if this video works. I'm not signed into. Okay, it's not going to work. This is a video about PEEP. And we're running out of time. So if you have the slides, you can go and look at it on your own time. So as I mentioned before, the two interventions that they did in the early studies were adjusting tidal volumes and low PEEP and using PEEP. So they did low tidal volume and high PEEP. And the high PEEP was guided by looking at the lower inflection point and adjusting the PEEP to above that, which is quite cumbersome and hard to generalize. You can, if you know what you're doing and you have the instruments to measure the inflection point, it's doable, but it's hard to generalize even to a large multi-center trial, let alone real world practice. So instead, what the ARDS trial was designed to do was to just look at high PEEP versus low PEEP. Tidal volume question was settled, low tidal volume is beneficial. The second question is, what about high PEEP versus low PEEP? And what they did was they set the PEEP based on two different tables. So this is FiO2 and PEEP combinations. So your goal is to get to oxygen level of above 90% or above 60, PaO2, and these are your combinations for the lower PEEP strategy. FiO2 of 30%, PEEP of 5. If you need more, you go up on the FiO2 to 40%. If you need more, you go up on the PEEP to 8, and so on. For the higher PEEP protocol, they had two because halfway through the trial, they found that there's not enough separation between the two populations, so they changed it. But let's look at this as an example. So you're on 30% 12 of PEEP, then 30% 14 of PEEP, and 40% 14 of PEEP. So you either increase the FiO2 or the PEEP. The difference between the two is you're on a much higher PEEP with the high PEEP. One limitation, it was a randomized trial, but by chance it happened that the higher PEEP group happened to be sicker. They had a higher Apache score, and at baseline they were more hypoxic. This is before the intervention, so it's not because of the intervention. It's just the randomization by pure chance led to an older population that were sicker and more hypoxic. And overall, the probability of survival, there was no difference in survival or in hospital discharge between the two groups. So it was a negative study. So high P versus low P, no difference now. And in that specific trial. Now, there are other trials that that looked at this question. And in a systematic review, if you aggregate all the data, there is a signal that high PEEP is beneficial, but it depends on the severity of ARDS. If it is severe, it seems to be beneficial. If it is mild, it's not. Patients without ARDS, it's harmful. So maybe the signal was diluted because they included milder and more severe ARDS. By the systematic review, this seems to suggest that quality of the evidence is not as good, but there is a potential for benefit from using high PEEP for the sake of using high PEEP. Now, if you need it to improve oxygenation, that's a different story. That's not what they did there. That's what they did was use it for the sake of improving outcome per se. You do run into, with these levels of PEEP, you do run into hemodynamic consequences. Once you get above 15, usually is when you start seeing decreased venous return, hypotension, and need for fluid boluses, etc. Now, there was a concept which physiologically it is sound, that one size fits all PEEP doesn't make sense because different people have different, not only lung compliance, but also chest wall compliance. And a lot of this pressure is used to lift their chest wall and is not really transmitted to the lung properly. So there was this theory of let's guide our PEEP by their pleural pressure, which is measured with an esophageal balloon. And this way we can customize it for individual patients. So we targeted transmural pressure rather than just give them high PEEP. This was a small pilot study that was done in 2008 and looked at that. And what they found is by using the esophageal pressure to guide PEEP, even though it was a small study, so the intervention total number of patients was 61, they had an improvement in 28-day mortality. The p-value didn't quite make it, was 0.055. With a small study and that p-value, that's very suspect. When they tried to extrapolate it to a bigger study, it really didn't work. So this was a 200-patient study instead of 61, and there was no difference. Last thing for today is driving pressure. So driving pressure is not something you set on the ventilator. Driving pressure is the difference between plateau and PEEP. And I've mentioned plateau a few times already. Plateau pressure is something you measure. It is the pressure that you do an inspiratory hold in the vent. Normally you can see the peak pressure. If you use volume control, which is what we often use, you set a target volume. And then the peak pressure is going to be determined by that. But the peak pressure is the end inspiratory pressure. It is partially a function of airway resistance. So to get to the meaning is the pressure at the ET tube. What we care about is the pressure at the alveolar level. To get to that, you need to give it some time to equilibrate. So you do an inspiratory pause. You see the curve go up and down, and then it plateaus. That's an inspiratory pause, and that plateau is called the plateau pressure. So it is a measure or an estimate of the alveolar pressure at the end of inspiration. The plateau pressure minus the PEEP is called the driving pressure, which is the difference between the inspiratory and the expiratory pressure at the alveolar level. This study looked at different variables that can predict mortality, and it found that driving pressure is strongly correlated with mortality in ARDS, meaning that people who had a higher plateau pressure and lower PEEP, or people who had a greater difference between plateau pressure and PEEP, tended to do more poorly. This gives us an idea who's going to do poorly, but it's, in my mind, this translates into, yes, these are people who have poor lung compliance, and this is why they have higher driving pressure. This doesn't tell us what to do in terms of how to ventilate them, because you do not have direct control over this number. You can, I mean, the only control you can do is go low tidal volume, because if you do, you're going to decrease your plateau pressure. If you change your PEEP, if you go up on the PEEP, the plateau will go up, because that's just your lung mechanics are what they are. You're not going to change that. You do not have much control over your lung compliance. By changing the PEEP, you may get your lung compliance to a better point, just because you're inflating it a little better or worse. That's a trial and error. So, in summary, there's improved survival with low tidal volume ventilation, targeting a tidal volume of less than 6 cc's per kg, plateau pressure of less than 30. There's no significant change in survival using high versus low PEEP, with a little asterisk that maybe in people with severe ARDS, there's a signal toward the change. The evidence is less compelling, but there's some signal there. Please use 6 cc per kg. At the VA, everybody has their height in CPRS, so calculating their predicted body weight is really easy. You don't need to measure them. When I was a fellow, I used to look for a tape measure to measure the patient's height, because that was the way to do it. I don't know. I'm not familiar with the current medical record system here anymore. So if you have their heights, just calculate, or there may be their predicted body weight is in the system, I don't know. But it takes a minute or 30 seconds really, and it's worth it. Do not estimate. Almost always miss. Like, look at you see people looking at the patient, he looks like he's 5'9". What does that mean? Like, he looks like he's 5'9". That doesn't, just get their height. All right, we'll continue on Friday. Any questions?
Just a quick question. The last part you mentioned, the driving pressure, is that kind of, I've seen in some, describe some ways to it, like you increase the PEEP and you see what the change in your plateau pressure
Yes.
is. That should kind of help you identify sort of an optimal PEEP. Is that kind of something we're doing commonly? We're trying to do?
I think it's a reasonable way to decide your PEEP. I'm not aware of any studies that looked at this prospectively and looking at outcome. I occasionally use it, like when you get difficult ARDS patients that are severe and that are somewhat hard to ventilate, and you're trying to decide what to do with them. I would occasionally do that. I think it makes sense. The rationale behind it is sound, and this data showing that driving pressure correlates with mortality supports that concept. So yes, I think it's a reasonable thing to do. It isn't backed by evidence, but it's one of these things that it's going to be hard to conduct a study that way. But since it is it's much easier to do than measuring an inflection point, right? It's like the ventilator will do it for you. You just can adjust the PEEP and see what happens to the plateau pressure. And that's very easy to do. And I think, yeah, I think it's a good idea.